Welcome to this ultrasound video tutorial on shoulder ultrasound. Ultrasound is a fast and effective tool for the diagnosis of common shoulder diseases, in particular rotator cuff abnormalities and impingement. During this video we will start off with a review of the relevant anatomy, then demonstrate how to perform the ultrasound examination. Finally, we will end with a few examples of the pathology that you might see. The rotator cuff is a group of 4 muscles that are responsible for shoulder stability. Understanding the anatomy and function of these muscles is crucial to performing the ultrasound. The muscles of the rotator cuff are the supraspinatus, infraspinatus, subscapularis and teres minor. For the purposes of a shoulder ultrasound, the teres minor is not always assessed and it does not contribute significantly to pathology. In addition to the rotator cuff, we also need to know about the biceps brachii muscle. Seen anteriorly, the biceps brachii has 2 muscle bellies and 2 tendons. The long head originates from the supraglenoid tubercle of the scapula and travels within the bicipital groove to join the muscle, while the short head originates from the coracoid process of the scapula. The subscapularis originates from the subscapular fossa and its tendon inserts onto the lesser tubercle of the humerus, as seen here. The tendons of supra and infraspinatus can be seen from the front, but to demonstrate their anatomy it is best to view them from behind. The supraspinatus originates within the supraspinous fossa of the scapula, and its tendons insert onto the superior facet of the greater tubercle. The infraspinatus originates within the infraspinous fossa of the scapula and inserts onto the middle facet of the greater tuberosity. Shoulder ultrasound examination is not easy to do, so it is important that you optimize your chances of success by selecting the correct tools for the job. To be able to assess the shoulder muscles and tendons, a high-frequency linear probe is essential. In this demonstration, we use a CHAN Medical multi-frequency 18.5 linear probe. The next step is to correctly position the patient. We recommend 4 key positions. Position 1, the patient sits with their elbow tucked into their hip and bent at 90 degrees. Position 2, the patient rotates their arm, moving only their hand out to the side. Position 3, the patient moves their hand around their back towards their contralateral back pocket. Position 4, the patient brings their hand forwards to touch their contralateral shoulder. With the patient in position 1, place the probe axially over the anterior shoulder. Here you will see the humeral head and the bicipital groove. The bicipital groove contains the long head of biceps tendon. Now turn the probe to assess the tendon in its longitudinal plane. It's important to keep the probe parallel to the tendon fibers to reduce the effect of anisotropy. Remember to tilt the probe over any areas of concern to ensure this artifact does not mimic pathology. Turn back through 90 degrees to the axial plane and slide cranially up the bicipital groove. The bicipital groove is covered by the transverse humeral ligament, which receives some fibers from the subscapularis. Now ask the patient to slowly rotate their arm into position 2. As before, rock the probe in plane with the fibers to ensure the anisotropy artifact is not misinterpreted. Now turn to view the subscapularis in its axial plane. There are multiple discrete bundles which represent the hypoechoic muscle fibers interdigitating with the hyperechoic tendon. This is a normal appearance and should not be misinterpreted as pathology. Rotate the probe back through 90 degrees and slide on top of the shoulder until the acromioclavicular joint is visualized. Assess this joint for bone contour irregularity, which is suggestive of degenerative change, and look for acromioclavicular ligament thickening as well. The acromioclavicular joint could also be widened, which would indicate joint disruption. Now, ask the patient to move into position 3 and angle the probe as shown to reveal the supraspinatus from under the acromion. Sliding anterolaterally across the humeral head will bring the tendinous insertion of the supraspinatus onto the greater tuberosity into view. Note how anterior the fibres of supraspinatus can be seen relative to the shoulder when the arm is in this position. While assessing the supraspinatus, this is also a good opportunity to evaluate the subacromial subdeltoid bursa. This fluid-containing sac overlies the superior aspect of the rotator cuff and acts as a cushion between bone, muscles, and tendons. In normal individuals, the bursa is a potential space. If the bursa becomes distended, this may be explained by bursitis or a tear in the rotator cuff muscles. Remember not to press too hard when looking for fluid in the subacromial subdeltoid bursa, otherwise you may compress the fluid out of the area of interest. Slide anteriorly to review the rotator interval, which is the space between the supraspinatus and subscapularis muscles, containing the long head of biceps, coracohumeral ligament, and the superior glenohumeral ligament. It is important not to mistake the rotator interval for a tear. Sliding posteriorly, you can see the supraspinatus blend into the infraspinatus without any visible gap between the two. To assess the infraspinatus properly, we must ask the patient to move into position 4 and place the probe over the posterior shoulder. Here we see the infraspinatus attaching onto the middle facet of the greater tuberosity. This is another opportunity to assess for pathological fluid in the subacromial subdeltoid bursa, which cannot be seen here. Finally, we review the infraspinatus in short axis. This concludes the standard shoulder ultrasound examination. Let's now look at some examples of pathology. One of the most common pathologies you might see is tendinopathy. Tendinopathy is a broad term used to describe chronic tendon damage. This may be seen on ultrasound as tendon thickening accompanied by loss of the normal fibrillar pattern, as seen in this example. You may also see calcification in the tendon as another sign of chronic tendon damage. This appears as hyperechoic areas with posterior acoustic shadowing. Tendon tears are another common disease entity. These can be divided into partial tears or full thickness tears. Partial tears typically affect either the articular side or the bursal side of the tendon. This example of an articular-sided supraspinatus tear demonstrates a hypoechoic cleft in the undersurface of the tendon. In this example, the partial tear is seen on the bursal side of the supraspinatus tendon. Note the intact articular-sided fibers underneath the torn bursal fibers. Sometimes the tear does not reach the surface of the tendon at all. Tears that are contained within the tendon, like in this example, are called intrasubstance tears. This example of a full thickness supraspinatus tear shows a cleft of fluid extending all the way through the tendon, with no real tendon left in between. You can also see that the ends of the torn tendon are retracted. This concludes our video on the ultrasound assessment of the shoulder. Please remember to like this video and subscribe to our channel. Thank you for watching.